Okay, so we are good to go. Thanks a lot. Thanks. I think we are there now, and I'm thinking people are connecting. We could wait a couple of minutes to see maybe a quorum. Okay, so I think we are not far from 100, so maybe 30 more seconds, and then we start. Okay, so thank you so much. Thank you so much, and welcome everyone. Good morning, or good afternoon, or good evening, everyone, depending on where you are. We are just very happy today to have you here in this webinar, this wonderful convening, where we'll be talking about the profile, the country profile 2025. So from wherever you are in the world, we appreciate the time that you spend with us in this session. So it's an honor to welcome you all in this important webinar. This is organized by the Countdown in partnership with UNICEF, PMNCH, Aluisio, and many other stakeholders who are here. So we are very happy that this is now happening. So today's discussion are particularly timely as we come together to launch the 2025 Countdown profile and other critical data tools that will support our collective mission to accelerate progress towards attaining the SDG goals. So particularly those related to health and well-being of women, children, and adolescents. So at the core of the countdown is a simple and very powerful premise. Accountability must be grounded in data. That's what we think is really critical and important, and that's at the core of this work. At the core of this work. With only 5 years remaining until we reach the 2030, our effort to track progress, highlight disparities, and support evidence-based decision-making are more urgent than ever. So it is important that we produce this type of tool, this type of document that could be used and useful for all the countries. As we move on to this, again, present myself as Dr. Cheikh Faye, the head of the APHRC West Africa Regional Office, and also director of the Countdown. So I'm pleased today to share and moderate this webinar. So we are going to facilitate this webinar in both French and English. So those who are join this webinar can select the language of their choice between French and English. So that they could follow up the presentation. And also on the top of the screen, you could see Chile's Welton screen and Roland screen. Chile is the English version of the slide. You click on that, you get the English slide, and then Roland, you'll be displaying the French slide. So you could select which one you want to listen to. So at this point, I think we have a very exciting agenda today, very interesting, not only by the content, but also by the high-level speakers that we have today in this panel. So I'm just going to open it up just to highlight a few things, saying a few things about the content, the profile, why they are important, and also how we aim to use them. Slide. Yeah. So just to mention that there's some history about the countdown count profile, although referring to UNICEF and other profile. So the countdown initiative was established in 2005 as a global collaboration to monitor progress in reproductive, maternal, newborn, child, and adolescent health and nutrition. Over the years, the initiative has expanded in scope and ambition, evolving to include a strong focus on equity, gender, and early childhood development. So that is ensuring that no one is left behind. So as a KPI of this work has been the countdown country profile, which is actually a very concise, data-driven summarize that provide a comprehensive snapshot of progress in LMNCH international level. These profiles are widely recognized in their role in, number one, tracking progress toward the SDGs and global commitment. That's one of the critical expectation of this profile. Number two is highlighting disparities, especially among the most vulnerable population, which actually are also very critical. This profile help identify those disparities. Number three, providing policymakers and advocate with the data needed to drive meaningful action. And lastly, but not least, fostering accountability by ensuring that government, development partners, civil society actors remain committed to their program. So that is really what is actually the aim and why actually we populate this profile. Slide. So why do they matters, this profile? Yes, it matters for many reasons, and I think it's important that we all agree on those key. Number one is this profile reflects the latest available data, revealing where we have made progress and where urgent action is needed. This profile goes beyond national averages, bringing a sharp focus to equity gaps by wealth, geography, by education, and other dimensions as stratifiers, so that we can address the systemic inequality that continue to hinder progress. So the profiles are more than just numbers on a page. They are a powerful advocacy tool that can, number one, empower government with the insight needed for better policy formulation and resource allocation, support civil society and media in holding leaders accountable for their commitment, but also inform global and regional development partners on where additional investment and technical support are needed. Slide. So at the global, regional and national level, we know that commitment alone do not save life, of course. It should be more, action does. So an action must be based on robust, transparent, and accessible data. The countdown profile provides that data, ensuring that government and partners have the evidence to course correct, prioritize investment, and address equity in LMNCH. Importantly, these profiles are not just meant for policymakers. We encourage researchers, advocates, and communities to use them to demand change. We must ask the hard question, and some of them are we truly reaching the most vulnerable children? Okay, so yeah, that's actually very important. And the other one is to say how far are financial resources being allocated where they are most needed, because that's also something that these profile are also a bit telling us. And finally, are policies translating into measurable improvement in health outcomes. Okay, slide. So as we move to how we launch this profile, I just want to end this introduction by saying that I invite you all to reflect on how we can use these data in our respective area of work, because we're coming from different perspectives, different profile. So whether in policy making, in research, in advocacy, in implementation, I think any of us have something to do or can do something to increase the use of this profile. So this webinar is an opportunity to explore not just what the data tell us, but how we can act on it. So I encourage all of you to engage actively in today's discussion and to think about how we can collectively leverage this profile to strengthen accountability, drive policy action, and accelerate progress towards the SDG. So I would like to thank you so much from here. Thank you really for understanding, for listening to this introduction. So I look forward to discussing and working together with all of you to ensure that every woman, every child, every adolescent has the opportunity to survive and thrive. So at this stage, as I've announced from the beginning, we are going to now jump into the main presentation, the main agenda. I think you may have seen the agenda of today, so where we will be inviting Dr. Tashrik Ahmed of UNICEF to take us through the remansage profile, which are the first set of profile that we are going to. So over to you, Tashrik. Thanks.
Thank you, Cheikh. Good morning and good afternoon, everyone. I am really pleased today to introduce the 2025 revision of the RMNCH country profiles. I'm Dr. Tashrik Ahmed, and I'm the lead for the data team for maternal, neonatal, child, and adolescent health at UNICEF. And I'll be guiding you through the initial stages of this presentation. Before we dive in, I'd want to extend a really huge thank you to some of the individuals who have made this possible, specifically Jennifer Roquejo with GFF and Bob Black from the Countdown to 2030 technical team that have provided extensive feedback on these profiles. And then within our UNICEF team, I want to extend some gratitude to Di Wang, Sahar Zandinia, and Kang So for their hard work in bringing this to fruition. As Cheikh was mentioning, these profiles are a very powerful resource because they bring together data from across agencies and initiatives in academic institutions and countries into a single resource that is targeted at action. So we see these as a valuable tool for anyone working to improve the health and well-being of women, children, and adolescents. So today we'll be covering some of the background and organization of these profiles, and then I'll hand it over to Di Wang, who's joining me on this call to provide a detailed walkthrough of how you can use these profiles and some of the data points that we've included this year, along with some of the new innovations. So next slide, please. So as Cheikh was mentioning, the RMNCH country profiles are designed to promote data use for improving reproductive, maternal, newborn, child, and adolescent health, or RMNCAH. They were originally launched back in 2005 with a very focused look on child survival, and that scope has broadened significantly to encompass the full continuum of care. These profiles are updated regularly, typically on an annual basis, to ensure that they reflect the latest available data. And a key strength of these profiles is their focus on intervention coverage indicators. The indicators that you'll see on these profiles are carefully selected by a technical team for their validity, their reliability, comparability, and actionability. And that's what we believe makes them a powerful tool for driving some positive change. Next slide. So to make the data easily accessible and digestible, we've organized them into 4 key sections. There are 3 main pages, and the last page is a mortality deep dive. The first page provides the basic context, so including the demographics table, an overview of equity across the continuum of care, and the trends and causes of death. Page 2 focuses specifically on maternal, newborn, child, and adolescent health and nutrition, presenting data in tables and trend graphs. And then page 3 shifts to the enabling environment, highlighting policy, financing, and environmental indicators. And then the 4th page offers a deep dive into some of the mortality data, and we'll explore how each of these sections works together to provide a comprehensive picture of RMNCH in each country. So with that, on the next slide, I will hand over to Dee Wang, who will take you through a detailed tour of the profiles. Dee, over to you.
Thanks, Tashrik, for the background and introduction. I just wanted to start by providing a summary of our 2025 refresh. So the last profile update was 2 years ago in February of 2023. So we've had some additional time this round with the update, and we really wanted to focus in on some of the feedback that we've received in past from different users. So some of our focuses this round included improving the design and organization. There's a lot of content on the profile, so we wanted to improve the interpretability of some of the results. Additionally, we worked on streamlining the data update process. There are over 100 indicators featured on the profiles, and so the update process in past has been quite a lift. So we made some efforts this round to make that process more efficient so that we'll be able to do more timely updates in future. We also added regional data, so we've added regional benchmarks to any of the trend charts you see so that you'll be able to benchmark national progress against regional data. Additionally, we've added French translations for our Francophone users, so the entire profile is available in both English and French for all countries. We've also added some high priority indicators this round after consultation with key technical experts. And on the next slide, you'll see the first page of the RMNCH country profile. So we'll be doing a detailed walkthrough today. The country profiles are available for all LMIC countries, with the exception of a few where there's just very sparse data. So we removed those countries. And before we go into the detailed walkthrough, just wanted to mention some general things that apply across the profiles. So the profiles feature both survey data and modeled data, and we've made an indication of what type of data is used under the different visualizations. The dashboard's also interactive, so you can hover over any data points to get more information on the data source, as well as data, the indicator definition, and in some cases, confidence bounds if the data is modeled. The profiles are also downloadable via Tableau, so if you would like to download an offline version, you're able to do that via Tableau. The full data set that's behind the dashboard can also be downloaded. Finally, underneath the country header, you'll be able to select the language of interest. So as mentioned, you can select between English and French. By default, we show regional benchmarks, but you'll also be able to select no regional comparison if you would like to just see the country level data. So moving into the walkthrough, the first page here really includes key contextual information on demographics, intervention coverage across the continuum of care, a look at subnational coverage of essential MCH services and cause of death data and mortality trends. So this is a zoomed in look at the demographics table, just to give you a sense of what types of indicators are included. So this includes population, birth, death, and contextual information. This year we added an additional gender indicator, the informed decisions for sexual reproductive health, as well as an environmental indicator, reliance on clean fuels and technologies. And on the next slide, you'll see a translated version of the demographics table. So all the indicator labels have been translated into French, and all the visualizations on the profiles have also been translated. Next on the slide, we have the Composite Coverage Index, or CCI map, which shows subnational CCI coverage. The CCI is a summary measure of coverage that is calculated as the weighted mean of 8 selected tracer indicators along the continuum of care. It includes indicators like demand for family planning, antenatal care, etc. This CCI data has been calculated by Pelotas using DHS mix and other national survey data. The data is only available where there's data for all 8 tracer indicators, so this won't be available for all of the country profiles. On the next slide, we have the continuum of care equity chart, which shows key interventions across the continuum of care from pre-pregnancy through childhood. We also feature some environmental and outcome indicators at the bottom. So in this chart, you'll see all the national data represented by the gray bars, and there's also data for the poorest and richest wealth quintiles represented by the red and green squares, respectively. So normally you'll see that the national data will fall between the 2 quintiles, but in some cases where sample size is smaller, you may see the national value outside of that range. And just a note here that all of the data is recent from 2018 and onwards, and it's been recalculated by Pelotas using DHS and mixed data. On the next slide, we're moving into the mortality and cause of death section of page 1. So in the upper left corner, you see the maternal cause of death data by MDG region, which is currently in the progress of being updated. So this data will be updated shortly. Underneath, we have the cause of death data for the different age groups provided by the CA code. And then moving on to the mortality trends, we have modeled data for maternal and child mortality. So the maternal mortality data is provided from the UN MEAG estimation process, and below that we have the child mortality data from the IGME process. Just wanted to note that this is all modeled data, so you'll be able to hover over the visualization and see the upper and lower confidence bounds for this data. And so the national data is represented by the green line, and the regional benchmark data is represented by the gray dotted line. And on the first page, again, you'll have the option to remove those regional benchmarks if you would like. And moving on to the next slide, we're going into page 2, which includes a more detailed look at some of the interventions along the continuum of care. So on the left-hand side, we have the focus on maternal newborn health, and on the right, child and adolescent health. And importantly, this page also features a number of nutrition indicators. So on the next slide, you'll see our 2 tables featured on this page. So they contain a number of maternal, newborn, child, and adolescent health indicators, as well as several nutritional status indicators. And then on the next slide, you'll see trend and age disaggregated data for key interventions across the continuum of care from pregnancy to infancy. These charts feature survey data, and you'll see in the trend charts that the survey data points have been indicated with different dots. And then moving on to the child health side of the second page, we have trend data on child nutritional status and interventions during childhood. So we have modeled data for these visualizations, so you'll notice the smoother lines in contrast to the previous slide. On the next page, we're moving into page 3. So here we present the different enabling environment factors that allow for intervention coverage improvement. So this includes legislative policies and governance, the environment, health system, and health financing. This page on the bottom right also has a glossary of terms used and some key notes on methodologies that users can refer to. So on the next slide, you'll see all the policies and governance measures. So we utilized a traffic light schematic here with green indicating the existence of a protective measure and red indicating the absence. And where we have no data, you'll see gray being used. Some of the indicators include code of marketing for breast milk substitutes, CSO involvement in national MNCH plans, and other indicators. And the data comes from a variety of different sources, including the WHO SRMNCH policy survey, as well as a number of different databases. Then moving on to the next slide, we're moving on to the right side of the third page where we have data on the availability of drinking water, hygiene services, and sanitation from the Joint Monitoring Program. And below that, information about the different building blocks of the health system, including health workforce density and availability of essential medicines. And finally, at the bottom, we have data on financing. So this is both official development assistant data that we're getting from the London School, as well as national government expenditure on health, which is coming from the WHO Global Health Expenditures database. And moving on to our fourth page, we have the mortality deep dive. So on this page, we have an expanded view of the causes of death and mortality data that you see on page 1. So moving to the next slide, you'll see a zoomed in look at the causes of death for the 1 to 59 months age group. So here, instead of only seeing the top causes of death, like on the first page here, you can see the full set of causes. And next, we also included 2 comparative mortality trend charts. So on the top, you'll see the under 5 mortality trends, and then on the bottom, over 5 mortality trends. And this will allow you to compare mortality trends across different age groups. And that concludes the walkthrough. Tashrik already did acknowledgements, but just wanted to mention again that we really appreciate everyone's contributions. This is a big team effort. So thank you to everyone, and thanks for listening.
Thank you so much, Tashrik and team. I think this is an impressive work actually that has been summarized very nicely in some pages. So again, on the chat, you could see the link to the country profile. So feel free to start browsing and looking at them. And also, I have to clarify that there will be a Q&A session after we finish the profile presentation, where you could engage probably, or just type your question on the chat and someone will reply to you. So feel free to use the chat box and put your comment or question there for us to look at. But there will be the Q&A session later. So thank you so much, Tashrik. This is the first set of profile, which is the RMNCH country profile, which is quite complete. So at this point now, we are going to move on to the next set of profile, which is the equity profile by our colleagues from Pelotas, Dr. Aluisio Barros. Aluisio, over to you. Thanks.
Okay, thank you, Cheikh. Hello, everyone. I am Aluisio Barros, Director of the International Center for Equity in Health based in Pelotas, south of Brazil. And I am going to drive you through the new countdown equity profiles. Next slide, please. So the International Center for Equity in Health has been working closely with Countdown since 2009. And we have been reanalyzing every new DHS and mixed survey since then, so that we produce stratified SDG indicators that are key to equity analysis. So we have a large selection of coverage and impact indicators in our database, and we add to those composite estimates, the CCI, the composite coverage indicator that Dee explained just a few moments ago, the maternal and neonatal health indicator that I'll explain soon, the antenatal care content qualified indicator for antenatal care, and the super global, that is an indicator of women's empowerment that we have proposed and created a few years ago. So all of these things are used to compose the countdown equity profiles. That next slide, please. Based on this big database that currently include 480 surveys, DHS mix and other types of surveys, 123 countries covering 32 years from 91 to 2023. Next. Next, please. Yeah. Well, given our current global scenario, I think it's timely to reinforce why do we need equity profiles. From the Agenda 2030, we can read, we envisage a world of universal respect for human rights and human dignity, the rule of law, justice, equality, and non-discrimination, of respect for race, ethnicity, and cultural diversity, a just, equitable, tolerant, open, and socially inclusive world in which the needs of the most vulnerable are met. This is quite a statement. And it implies that health is a human right, and every person is entitled to enjoy the best possible health status. And then it is our duty as governments, as managers, as researchers, advocates, to make sure this happens. Next. So the equity profiles reveal inequities and prompt stakeholders to act. Next. So the new equity profile, it has 5 pages, and the first page looks like this. And so what's new here and why? So we have new indicators. So we have the 0 MNH, maternal and neonatal health indicator. I'll define it very soon. We have a 0 dose indicator, that is children with no doses of vaccine. And these are important to highlight marginalized groups within each country. We have new stratifiers, women's empowerment and different levels of empowerment, women's age, ethnicity, and religion, in a way that we cover a wider set of equity dimensions, including some that are not so often used, and focus on gender. That is something that is key to our equity analysis and focus. Next. So the profile includes 15 indicators, individual indicators, plus 3 combined indicators. So the 15 individual indicators cover reproductive health, maternal and neonatal health, child health, breastfeeding, and nutrition. And so they are presented in graphic form, in graphs, and in tables. The combined indicators, we have the CCI, Composite Coverage Index, that is a weighted average of 8 indicators in the continuum of care. We have the 0 MNH indicator, that is the proportion of mother-baby pairs that had less than 4 antenatal care visits during pregnancy, a birth outside of a health facility, and no postnatal care for the mother or the baby. So 0 care, or nearly 0 care, for the period of pregnancy and delivery and neonatal period. And then we have the 0 dose indicator, that is the proportion of children 12 to 23 months who received 0 doses of DPT or pentavalent vaccine. So these indicators next are presented in the first page as a map in equiplots, where we plot the good coverage indicators, and another set of equiplots where we have these sort of bad, undesirable indicators by different set of stratifiers. So let's focus on each of these parts of the report. Next. So the map presents the CCI coverage by subnational region. Is usually admin 1 level division of the country. So to highlight subnational inequalities. So the example I brought is Senegal, and we can see that the CCI covers are not so low, but they vary a lot. So they go from 54 in Matam up to 71 in St. Louis. So using the map, and we have the numbers for each of the regions, you can have a look at the level of subnational inequalities. Next. We then present the set of coverage indicators by wealth quintiles. So that it's a more detailed presentation than you had in the general country profiles that were presented before this. So we have the 5 wealth quintiles here, and you can see how coverage changes from the poorest to the richest in the country. So typically we have wide gaps and, well, higher coverage for the richest groups and much lower coverage for the poorest groups. It varies a bit across different indicators, of course. And typically, there is one exception, unfortunately, that is breastfeeding, where most often we see much higher prevalence of breastfeeding among the poorest groups than the richest. Of course, what we wanted was to see high levels of breastfeeding for everybody. Right? Next. The other equiplot we present is the same set of indicators now by urban-rural residents. And here we usually see urban populations doing better with higher coverage than the rural populations. And again, usually the exception to that are the indicators related to breastfeeding. So in this case here, Senegal, you see that early initiation of breastfeeding is more common in the rural population than the urban population. And next. So the next part of the page shows these sort of undesirable bad indicators. 0 maternal and newborn health, and 0 dose prevalence. And they are presented by ethnicity, by religion, by level of women's empowerment, and by women's age. So in the example of Senegal, we see, for instance, relatively low prevalences of 0 MNH. That's very good. So small percentage of the population has no access to maternal and newborn health. When we look at 0 dose, that's not so low. And we see, for instance, larger gaps when we look at 0 dose by ethnicity and by women's age. So the proportion of children, 0 dose children, is much higher when we look at very young mothers between 15 and 17 years of age. We also show religion, right, and women's empowerment. For religion and ethnicity, what we did for the graphs is to select the 6 most common groups of ethnicity And the same for religion. Religion is usually not as many groups, but ethnicity in some countries, there are a large number of different ethnic groups, so we can show all of them. So we show the ones with the higher frequencies in the population. Okay, next. Okay, page 2. Page 2, 3, and 4, you see that we show tables with the actual estimates so that you can check the exact numbers that are the coverage for each of the indicators used by each of the stratifiers. So you can compare the numbers themselves. You can use these numbers for further explorations and do your own analysis and so on. And in page 2, we also add, just beside the wealth quintiles, wealth-related equity indicators. So we have the ratio between the richest and the poorest in the population, the difference between richest and poorest, the concentration index, and the SII. So measures of inequality related to wealth. Then we have, next slide, page 3. We have the coverage of our selected indicators by subnational region. So we have all of the 18 indicators presented by region. So you have the numbers for each of them. For some countries, large number of regions, you'll see a relatively busy table, but the numbers are there. Next. Page 4. Here we have estimates of these bad indicators by all the stratifiers that we used in the graphs. So we have by urban rural, we have by women's empowerment, women's age, ethnicity, and religion. We have a separate page for that because the number of groups vary a lot. So we needed, for some countries, more space and prefers to have them in a separate page. So again, numbers that you can use for more specific evaluation and analysis. And next, finally, we have our last page, where we presented general explanation of the profile, what it is and its aims and so on. Detailed definitions of each of the indicators that we present. Especially, we explain what the CCI, zero dose, and zero MNH are. And there is some help in terms of interpreting the graphs as well, so that if it's a bit hard to start with, there is some guidance in terms of how to interpret it. So next, the profiles can be found in the Countdown to 2030 webpage. We've so far have 15 of these new profiles prepared, but on that page, you will find profiles, the old style profiles for the latest survey in each country for 118 countries. So lots of information available. You can just access the page and, well, enjoy. Next. That is all from me. Thank you very much for your attention. And, well, I hope you really make very good use of these profiles. Bye.
Thank you so much, Aluisio, for this also wonderful presentation of the equity profiles. I think they are quite rich. You looked at all the dimensions that you were able to include. And I think this is really unique and really add a lot of value in understanding those disparities within countries. Thanks a lot for this great job. Of course, for people attending this webinar, we still say that this is the launch of the 2025 Countdown UNICEF on the profile. So the tools are available. You could access them from the chat. There are links being shared, and the country profile are also provided in 2 languages, depending on the countries. So we thank you so much. So there are some questions in the chat that I invite my colleague to look at and respond to those who are on the panel. Some are just a basic question, but we may also come back to some of them in the next session. So at this point, we are going to move on to the next set of profile, which is one of the very powerful and important one, the ECD profile by Professor Linda. So Professor Linda, over to you. Do you hear me, Linda?
Yes, thanks very much, Cheikh.
Okay, proceed.
Shelley, are you moving my slides on? Is that, or am I doing it?
I think you can proceed if this is the same slide. But here you see
I'm sharing my own slides.
Okay, wonderful. That is fine. Proceed.
Thanks very much, Cheikh. Right. So my name is Linda Richter from the University of the Witwatersrand in South Africa. I'm presenting the Early Child Development Country Profiles, which we see as a resource for monitoring and action, on behalf of a technical working group. We work with UNICEF to initially to develop the profiles and now to update and maintain them. So like the other profiles, these profiles assemble in one place the latest information to assess and monitor country progress in improving the health, development, and future prospects of young children, children under 5, all over the world. One thing that is quite unique about the early child development country profiles is that they actually mirror the conceptual framework developed for early child development in the 2017 Lancet series, From Science to Scale. In that series, we conceptualized early child development as being multi-leveled and multiply determined. So we saw the enabling environment, the facilitating environment, as critical to supporting at the family and community level the components that protect, support, and promote early child development. So at the facilitating level, we have enabling policies, supportive services, empowered communities, and caregivers. At the level of the child, we have inputs that promote good health, adequate nutrition, responsive caregiving, security and safety, and opportunities for early learning. So these profiles are uniquely designed to support stakeholders who are taking up the nurturing care framework. Now, it's only one page, it's colorfully designed, it mirrors the nurturing care framework in its look and feel. It consists of 4 sections. The top section is demographics and threats to early child development. So we have things like the numbers of children under 5. Threats to child development would include indicators like exposure to violent discipline. We then have outcomes or impacts, so estimates between 2005 and 2015 of young children at risk of poor development, broken down by rural, urban, and by gender. And we have the number of children with functional difficulties and the number of children who are developmentally on track as measured by the ECDI. We then have the 5 components of nurturing care: health, nutrition, security and safety, early learning, responsive caregiving. And then the facilitating environment, which consists of policies that support families to care for young children, such as parental leave, child and family social protection, and so on. Now, the data is like the other profiles. We have no model data. We extract from comparable and publicly available global data sets. So every country is reflecting common country comparable data. The data comes from the UNICEF multiple indicator cluster surveys, the DHS, other nationally representative household surveys, and agreed model estimates, such as stunting. This is one of the few. And then country data published in high impact journals, And it's like the equity profiles and the MNNCH profiles. It's accompanied by a technical appendix with all indicator definitions, dates at when they were sourced or collected, and together with the underlying Excel database, so can be used by people who want to use the data to break it down in other ways. Now, nurturing care has grown very rapidly and very solidly. It's almost, I haven't seen a country document on early child development or a large organizational document or foundation document on early child development that doesn't take the nurturing care framework as its starting point. And the country profiles have expanded with the nurturing care framework. So when we started, we only included 91 countries. We then expanded to 138, and we now include 197 countries, and we update them biannually. Of course, many of those countries do not have data or have incomplete data, but we include them in order to highlight which countries do and do not have data. Now, we do quite a lot to disseminate this information to the stakeholders in early child development, to include parent groups, community organizations, service sectors, governments, funders, and so on. They include, for example, translations from English into 4 other languages: Arabic, French, Russian, and Spanish. We have also developed regional profiles on requests, and with those regional profiles have actually launched them at launch events to discuss with countries in those regions. And you can see the number of countries in each of the regions: 41 in Asia Pacific, 10 in East Africa, 8 in Central, 10 in Southern Africa, 16 in West Africa. So at the launches, we then were able to break down that regional data by countries so that people could see the detail. So we've done many presentations on these data, as I said, to government representatives, community, civil society organization, community groups, funders, and foundations. And these are some examples of those presentations that we've done. We also aspire to the kind of rich publication, peer scientific publication record of Countdown, and have a number of publications on aspects of the country profiles, really generated from a research project that accompanied the Countdown, the Early Childhood Development Countdown, called Global Data on Children. And here are some examples, and on the website are several more examples, but very easy to source these publications. Now, data raises awareness. So perhaps one of our most outstanding pieces of data is the data that came from the Lancet 2017 series, From Science to Scale, in which we estimated that 250 million children under the age of 5 are at risk of not reaching their developmental potential because of poverty and stunting, extreme stunting, looking at children living in who are living on less than $2.15 per day, the World Bank definition. That's about 43% of children. And as you can see from this graph, those in the orange color are where more than 60% of children are, or below 60% of children are at risk, and the green countries mark children where there are 40 to 59% of children at risk, more than 60%. So this indicates very clearly the disparities regionally across the globe, so that you see in Africa, in sub-Saharan Africa, we have predominantly countries where more than 40% of children are at risk of poor development, and you see a similar picture in Southeast Asia. And this has been an extremely mobilizing statistic. There are thousands, literally thousands of references to it in the peer-reviewed literature and in advocacy literature and funding literature and so on. Now, the way the data is being used, and which we are promoting, is that it highlights these kind of disparities. the disparities between regions, between countries, between locations such as urban and rural, between genders, boys and girls. This encourages uptake because it focuses and makes relevant the data to the people who can do most about it at the country level. It facilitates knowledge sharing and learning across the regions and countries. We wanted to foster local research, and it helps people to tailor their advocacy efforts to key issues. Now, we would like to see the country profiles leveraged a great deal more. It's a high quality, largely untapped research for countries that can identify key data gaps, monitor progress over time, and propel action for change. We need to expand global data collection. At the moment, many of the indicators come only from the mix, the multiple indicator cluster surveys. And so we are mobilizing and advocating for the optional inclusion of the ECD module in DHS. Unfortunately, that process is coming to a little bit of a halt just because of the crises going on in funding in the United States right now. But country investment is needed for regular data collection on a standard set of indicators, country comparable indicators, to fill data gaps and generate data to access trends. I'm always embarrassed to confess that South Africa has no data. If you look at the country profiles, you'll see that South Africa is blank. And we need to accelerate efforts to collect, use, and disseminate this data to improve outcomes for young children in the last 5 years of the SDG agenda to 2030. Now, what are we going to do in 2025 to update and increase the relevance of the early child development country profiles? We're starting on a comprehensive review of existing indicators. We initiated these country profiles to parallel the release of the Lancet series and the whole notion of the nurturing care framework. So many of those indicators need a rethink. And we want to relook at those indicators to ensure that they reflect the critical drivers of ECD and what is needed for young children to thrive. Of course, there's a lot of data that's not yet available. For example, the key construct of responsive caregiving is proving, although we have observational means of assessing responsive caregiving, it's proving much harder to identify a feasible small set of indicators that can be included or questions that can be included in a questionnaire. We also need to refine for some of the indicators, for example, maternity leave. That's an indicator that undergoes change. For example, in my country, there's been change to paternity and parental leave, and some of the data sources, for example, on child poverty. We also want to update the estimates of the percentage of children at risk of not reaching their developmental potential, because this is such a mobilizing statistic, and we hope to release this update in the last quarter of 2025. Like the other profiles, our early child development country profiles can be downloaded on several websites, including the UNICEF, the Countdown website, the Early Child Development Action Network, and the WHO Nurturing Care website. It includes the country profiles, the data definitions, the dates, the technical details, as well as the data set. So again, like Aluisio said, I really hope that people become aware of the early child development country profiles and are motivated to use them. Thank you very much, Cheikh.
Thank you so much, Professor Lindarish. I think this is, again, a very nice tool, nice profile, and I think it is quite impressive to see the work behind from your team, and thank you again for the hard work. So we are now moving to an application of the gender lens into this profile, because this profile, each of them could be looked at in a certain way. And I think our team have been working hard on, bringing a gender lens. So Elizabeth from Hopkins and team have done wonderful work. So we invite them to share and come in, share before we open the floor now for Q&A. Elizabeth?
Yeah, thank you. Good morning and good afternoon, everyone. Again, my name is Elizabeth Hazel from Johns Hopkins University, and I'm speaking on behalf of a larger team at JHU and also the Countdown to 2030 Zambia team led by Dr. Troy Jacobs. All right, so how can you use these profiles to integrate and track progress on gender equality and RMNCH outcomes? So I'll talk a little bit about that first, and then we'll go into some examples of a country profile using the country profile in Zambia, and then also a more in-depth gender analysis. So first, some definitions. Gender inequality is the balance of power, resources, and options that disadvantages women and girls. And because women and girls are the largest recipients and providers of RAMCAM care for themselves and their children, and they face disadvantages because of gender inequality and both receiving and providing these services and care, this means that we need to both look at health and gender outcomes. Next slide, please. So when we're talking about doing a gender analysis of these RAMCAM indicators, we can think about it from sort of three different perspectives. The first one is thinking about what are the gender inequality dimensions of these specific outcomes. The first, we would want to ask ourselves, are health services designed and delivered in line with women's and girls' needs and preferences? Do girls and women have a decision-making role in whether and how they can access those services? And what are the gender inequalities in health systems that shortchange their effectiveness when they're actually being accessed? We can also think about three different types of gender indicators and data. There are indicators or data that is sex specific. The maternal health indicators are considered gender sex specific because women are the ones that access them. We can also think about gender indicators and data that is sex disaggregated. So looking at indicators, health outcomes between boys and girls, for instance. And then we can also think about systems level data. How are the systems structured that can support women and girls to access these services? The third perspective that we can think about is we need to think about gender analysis and understand that it's context specific and also intersectional. So of course, the way that these gender dimensions and power structures manifest is that it's going to be different in different contexts, even between different countries, but also within countries as well. And then it also intersects women who are poor, who live in rural areas, lower education, maybe different races or ethnicities are going to have different experiences when they access these types of services. Okay, slide, please. So as we've learned to this day, the countdown profiles contain a rich array of data on the health of girls, women, and mothers. These profile indicators were selected to be consistent and comparable across countries from readily available data sources and to enable progress assessments towards the related SDG goals. So given the focus on girls and women and the disaggregation that is provided in the equity profiles, these profile data can be used as an entryway into more in-depth gender analysis. Next slide, please. So we'll be doing that just now using the Zambia country profile. I'll be highlighting some of the indicators in the profile that are gender relevant and providing a short explanation on that as well. Next slide. So first, we can look at the profile and understand the status of adolescent girl well-being, social status, and nutrition. So for instance, we can see in the profiles that a third of girls are married before the age of 18 and understand that child marriage is prevalent in Zambia. And the reason that this is a gender issue is because child marriage puts girls at a higher risk of poor health, violence, exploitation, poverty, and is a human rights violation. Next. And although overall secondary education completion is low, girls have a lower level of completion, indicating that there are gendered barriers to accessing secondary education, completing it. Next, please. Yeah, given the in-depth cause of death, the data that is presented in these profiles, we can look at the difference between the causes of death between boys and girls. So this is an example of sex disaggregated information. So although HIV and NCDs are top causes for both adolescent boys and girls, the third leading cause of girls is interpersonal violence, signaling violence and abuse towards girls. And of course, that's a critical gender issue. Next, please. We can also look at nutritional status. So although adolescent girls have higher prevalence of overweight obesity than boys and associated higher risk of obesity-related morbidities now and as adults as well, but these sex differences are minimal, 5 percentage points higher for girls nationally, but still important to consider. Next. All right, so we can move on to looking at reproductive and maternal health, looking at the national and data trends that's available in the country profiles. And from just looking at this, this snapshot of the data, we can understand that there are important barriers to contraceptive access in Zambia. So overall demand for family planning services satisfied is lower, but there do seem to be additional barriers for poorer women. Zambia also has a total fertility rate of 4, indicating that the family planning barriers for women are serious, especially among poorer women. Next slide. 4 more visits of ANC is only 64%, and coverage of skilled birth attendant is at 80, both with increasing trends in the past 20 years. Postnatal care for mothers is 70% with inequalities by wealth, and these data show that preventive maternal care during pregnancy and postnatal is low, and again, lower among poorer women. So again, this is a gender issue since some women are not getting the care that they need. And then the maternal mortality ratio in Zambia is lower than the regional average, as shown in the profiles, but still high. And looking at the leading direct causes of maternal death, noting that they're hemorrhage, hypertension, this really does indicate suboptimal quality of care for mothers. Next, please. So Zambia is really committed to addressing these health issues as shown by their national policy and guidelines to improve quality of services. And there's also a national policy to review and notify about maternal deaths. Their national abortion policy allows abortion to preserve women's physical and mental health, to save her life as well. Slide. And then finally, health workforce is low. Below the WHO recommendations for doctors, nurse, midwives, population density, midwives are authorized to perform delivery care, including administration of oxytocins, antibiotics, and instrument-assisted delivery. And also, we note that Zambia is committed to addressing these health issues as shown by their national policy and guidelines to improve quality of service and a national policy to review and notify maternal deaths. Okay. Last slide. Next slide, please. So now I will switch over to discussing an in-depth analysis of the data related to respectful maternity care policy enacted in Zambia. So sorry, it's a bit light to see on the screen. I will say that we looked at the national data on BMOC facility readiness that was available in the most recent harmonized health facility assessment and noted that the primary health facilities were worse off on equipment, medicines, commodity staff, and guidelines being inadequate at all the facility levels. So that sees the blue is the staff and guidelines, purple is the availability of equipment, and then green is the medicine and commodities. And so although there's no national data on women's experience of delivery care, we were able to bring in some information from a study in Lusaka and unplanned settlements in 2022 and found that women, particularly without spouses, faced especially long waiting times, mistreatment, discrimination, stigma, and that the providers not only lacked training, but faced challenges due to staff shortages, overcrowding of patients, work overload, and limited equipment and supplies. All right, so I'll end by saying that, again, I'm speaking on behalf of a much larger group of the Monitoring Action and Gender Equality. You can see a bit.ly link and a QR code to our website, and also, again, behalf of the Countdown to 2030 Zambia team. Thank you.
Thank you so much, Elizabeth and Kim, for this very great work as well. I think it's always good to bring in this dimension. We never talk enough about gender. And I think if you look at this profile, the way they are structured, at any point you could see the gender gap and some of those new information that could be very useful for programming or policy. So thanks a lot, and thanks also to your team for this great work. So at this point, we are going to now open the floor to go to a Q&A session chaired by Robert Black. Bob is here. So we are handing over to Bob to facilitate the session. Thank you. Bob, over to you.
Great. Thank you, Cheikh. We've had 4 excellent presentations on these important profiles and a great detail that is included in all of these profiles. So perhaps we have stimulated some questions, and I'll just get started while we're looking at the questions that come up. Start with a question from us to UNICEF, maybe Tashrik or Dee. You've made some real important improvements and additions to the profile this year. Could you tell us more about how UNICEF is using the profiles in country or regionally, or perhaps at headquarters? So just give us a sense of how you use this particular profile, or perhaps the other two profiles as well. Tashrik, could you perhaps you could respond? If not, Tashrik, Dee, are you still there?
Hi, thanks. Yes. Yeah, so I think one of the uses of our country profiles, a lot of our country offices will use the profiles to just get a stock take of the situation in country. So oftentimes people will download the entire profiles and yeah, just get a sense of what the general trends in the country are. So there's a wealth of yeah, material in the profile, so they're able to really pinpoint different areas that they're interested in. And oftentimes the visualizations of the profiles are also used by our different country colleagues and regional colleagues. Yeah, there was a need indicated by our regional colleagues for some integration of the country data with the regional data, which is why we added the regional benchmark data this year to allow, yeah, for that comparison of national and regional data. So yeah, we really see the profiles as a key resource for our different offices globally, and so we think it's a good starting point to just pinpoint different areas that country offices may want to focus in on for their planning purposes. So yeah, I hope that answers the question. And Tashrik, I'll let you come in if you want to add anything.
Hopefully you can hear me now.
Yes, can hear you.
Okay, sorry about that audio issue. No, I think Dee covered it well. I think a few other points. We were actually sharing these RMNCH profiles across our East and Southern Africa health network meeting that was happening over this past week, and there's been a lot of good reaction. I think in addition to some of the use cases that Dee outlined, I think just showing the data gaps itself and where countries don't have data has been a really powerful tool to advocate for better data collection, better data quality, and to understand, how are decisions being made without this critical information in country. The profiles are also used as a starting off point. It shows the national data, but then, the natural question we get from countries is, what does this look subnationally? Can we look at inequities? So it's a good place to understand the gaps, to work with country officials on, where are the areas that we need to focus, and then what are the steps that we need to work together with other partners to dive deeper. Back to you, Bob.
Great, thank you. Well, while you have the floor, let me ask another question that was in the Q&A. The question is, for all of the country profiles, is the analysis of causes of death, both maternal and infant or child, only carried out at regional level or also at country level?
Thanks, Bob. I think you might be better placed to answer this one, but it depends on the specific age grouping. So for MMR, that data is carried out regionally. I think countries have their own estimates as well that are available. But the causes of death for maternal death are done at the regional level because of some of the lack of data. Dee, do you want to come in on child?
Yeah, so the child cause of death data is available at the country level. As Tashrik said, the maternal cause of death just at the regional level, corresponding to the MDG regions.
Thank you. Don't see any other questions in the Q&A, so let me just ask one for Linda. You mentioned a lot of the dissemination activities, very impressive, very active dissemination, but yet you say that there's still more to be done to get the use of these profiles. So could you expand a little more on what you would like to see more in regard to use and how the participants in this webinar could really help with that? What would you like them, like all of us, to do?
Great, thanks very much, Bob. I think that we would very much value a closer association with the RMNCH in profiles, so that when they have meetings, we could perhaps attend, members of our technical working group or UNICEF early child development people or other parties in the country, so that people begin to see the child health pieces as complemented by child development pieces. That would be very valuable. Of course, equity is also a critical issue for early child development, perhaps one of the most sort of salient things that stand out. And so, you know, we try to emphasize the equity issues ourselves, but again, closer integration between all of these profiles would be very useful. I know that from UNICEF's side, Claudia Kappa and the data team have been really wanting much closer linkages with statistical officers in countries who could perhaps work more closely with interested stakeholder groups to understand the data. I mean, we've tried to do quite a lot of this, and I'd be interested to know what the other profiles face in terms of this, but many country level users are sometimes perplexed by the selection of the data. So why does, you know, a local survey in Zambia, for example, show a certain percentage of an indicator, and yet your statistics show something different? So getting across this idea of standard indicators, country comparable indicators, and at the same time acknowledging that there is local country data that countries can use, but the purpose of the country profiles is to give this comparative data. So we would like to have all the opportunities we can. I mean, the Lancet series and the country profiles have brought together a global ECD community, which has taken the form of EGDAN, the ECD Action Network. And so there are very close links between program people, parenting groups, funders, foundations, governments, and so on. And this is a very good network for dissemination, but nonetheless, we want to stimulate more research. So we actually had a large UK grant to begin to analyze data in a more systematic way, emulating what was done in Countdown. But we would like to see more local research using the data that is available on children. Thanks, Bob.
Thank you, Linda. There are some questions in the Q&A, but there are participants who are responding to those directly, so I won't ask those, but I will ask one that is in the chat that I don't see a response being typed to, and that is how do these data translate into recommendations for the improvement of RMNCH services in country? Obviously, that's the intention, but how have you seen, maybe this is for the experience of those who are participating in this, perhaps from Countdown itself, from Cheikh, or from UNICEF. So how have you seen the direct translation of these kind of tracking data of the progress feeding into recommendations in country? And I could ask Tashrik, and then maybe a comment from Cheikh as well, to see if you have specific experience and how this has contributed to recommendations.
Sure. Thanks, Bob. These are tough questions, but I think they're good questions. So for the RMNCH profiles, again, I think we really see this as a starting point. It helps countries to understand where to prioritize, how to mobilize resources, what are the gaps. And I think Elizabeth's presentation really kind of highlighted some of the questions that can arise with close inspection of the data. we have examples of how this is used, I think, especially when our health specialists in country, our ECD specialists, I think our adolescent health specialists, all have different framings when they look at this. And so whether it's looking at data gaps and really reinforcing what the monitoring and evaluation framework looks like, what surveys are needed to advocate for specific modules that go to DHS and mix to close those gaps, whether it's for programming where you're looking at trends over time and seeing where there's progress and where there's not. And we've also seen these profiles get screenshotted and put into resource mobilization grants to really drive home to donors like Gavi and Global Fund around these are the gaps. This is how we're benchmarked across different countries in our region. There's another question that I think is also important around the difference between some of these local data versus global data. And I think one of the big pieces here is that I mean, country data is really important for me. That's going to be the way forward. But being able to compare what's happening in your country to other countries in the region and other countries in the globe is a really powerful resource mobilization tool that I think countries should leverage. So, I mean, I think the use cases here are really varied and really powerful. So I would really encourage countries to really take a close look and understand what this means to you.
Yeah, just to add that, I think that's a very good point, Bob. And from experience, I think countries have different stories. In the past, there have been some national level engagement where you have some meetings presenting the profile, staying on the fact, but leaving the country to decide on what it means for them in terms of program and policies. We have a couple of cases where there have been quite some way forward into translating some of those results or facts, adjusting some policies some here. But that's really mainly when, for instance, they have a recent survey that have been taken into account. For instance, if a survey came out last year and it was factored by the profile, most likely it may lead to some adjustment here and there. But the country profile themselves, they don't provide recommendation, which is normal because we limit ourselves to the facts, the results, and then countries, depending on where they are implementing their program, will decide on what it means for them. And I think it's a tough thing, but it is moving here and there depending on the countries. But thanks.
Thanks for all the responses. I know we're out of time, and I would just say two things. One is if there are continued questions, we put those in the Q&A, and we'll try to get presenters and others to respond. And Linda, I'm sorry we ran out of time. I see your hand, but if you have a comment, put it in the chat. I'm sure people would like to know your experience as well. So I know we're out of time, but I don't want to get in trouble by running us over. So Cheikh, back to you.
Thanks so much, Bo. Thanks. You did very well. I think this discussion will not stop because I'm sure we'll follow up on email here and there and probably as well on the chat. And I see some very good questions as well. But to be complete in this spectrum, I think we were moving to a concrete example, which is still connected to the old work, the countdown chat book, which is a very good report or summary of results that Countdown have been involved over the last year. So we invite Tis Boma to take us through the country chat book that were populated from the Countdown. Thanks. Tis.
Thank you, Cheikh, and thanks everyone for joining, and also to PMNCH for organizing this rich webinar. I'm Tis Boma from the University of Manitoba, and very much affiliated to the Countdown. So after this parade of profiles, which are, look very smart and are great synthesis of particularly survey information, we're going to talk a little bit about the country chart books. Next slide, please, Shelley. And Roland. So we're talking about strengthening monitoring using surveys and facility data, and monitoring obviously for review of the data and then for action, advocacy, accountability, etc. And that countries would need data for national, but also regional and district monitoring of the RMNCH and primary healthcare indicators to inform national plans, what's the progress, new strategies, local implementation, and also to monitor global targets, some of which are subnational and increasingly so these days. The main data sources are, as we heard, the surveys, DHS and MIX, good quality data, usually clean data, but they're not frequent enough. There are no district data, and there are data gaps. Some things just can't be collected well in the survey. And there are the health facility data, which ministries of health rely on a lot. These routine monthly reports, sometimes referred to as the HMIS, the Health Management Information System, or DHIS2. And there are other sources like health facility assessments. So we're going to focus on the facility data. Next slide, please. So routine facility data, there's some progress. Almost all countries have now some kind of web-based system, mostly DHIS2. There's some standardization of the data that are collected and indicators. There is some improvement in access to these data for instance, public health institutions and others in the countries. And there are tools for using facility data within DHIS2, but also others. And there are major challenges. The quality of the data is often problematic. The events, how many antenatal visits, etc. There is, if one wants coverage estimates, a need to estimate the target population, which is not only those who came to the clinic, but also those who did not come for services. And it's challenging to combine survey data and facility data-derived estimates and present those in an integrated way. And we noted that that was not done very much yet. Next slide. So in the countdown over the past years, in collaboration with GFF, we've been working on strengthening survey analysis, but also facility analysis, using standard tools for data cleaning, analysis, and presentation. And these country collaborations operate throughout the year, but this culminates in a country annual meeting, which is organized with GFF to produce statistical chart books. And this is a picture of our last meeting in Rwanda, which included 26 countries. Next slide, please. These are all countries in sub-Saharan Africa. This is a network that's led by Cheikh's institution, APHRC. And the result of that meeting are these chart books. And I'm going to give you some examples of what's in these chart books. It's not a sort of polished profile, as we saw country profiles before, but it has some really interesting information. Next slide, please. So first of all, with facility data, one needs to go very thoroughly and systematically about what is the quality of the data. As with any data, there are always problems, but you need to describe those and you need to look at the completeness of reporting, and we make adjustments to deal with that. One needs to eliminate extreme outliers, and one needs to deal with inconsistencies between reported numbers. For instance, the third dose of a vaccine cannot be higher than the first dose, or antenatal first visit and penta first visit need somewhat to be correlated. So that's how it all starts. Next slide. Then countries move their analysis, and all these countries are done by themselves with their own data sets, but we provide tools and guidance. And so then one needs to move to data quality assessment and for the denominators. What is the denominator? The number of children, say live birth for deliveries. They're in DHIS2, but unfortunately, they're often quite a ways off, and these are based on population projections. So we have been working for over the years to provide alternatives, which are particularly useful for countries that have very high coverage of interventions, such as first antenatal visit could sometimes be well over 90%, which means that the reported numbers that we have in the health facility data should be close to the total target population. Only a few need to be added because they didn't come. And so for most coverage indicators, countries have selected ANC1 as a denominator basis for their maternal and newborn health indicators, and Penta1 for immunization indicators. Next slide. So a few of these results. So this is national coverage trend. So Zambia, for instance, did the last DHS survey in 2018. But one would really want to know in Zambia what's going on right now. So the coverage data estimated with the facility sources provides an insights in, hey, there's some stagnation in the increase in delivery coverage, but it seems like cesarean section rates are still going up. So that is done for a number of indicators that are listed here for the national level. Next slide. But then it gets really interesting because obviously with facility data, one can drill down, one can look at the subnational level. Facility data are a good source. They're even better if they're used in combination with the survey data. So we we have tools to look at sort of the regional, provincial level, but also, and that gets more complicated, at the district level for various reasons. And for instance, has the difference between the districts, the inequalities between the districts improved over time, which is often one of the targets in national plans. Next slide. We also work with the country teams to get analysis of the maternal mortality data that can be in the DHIS2 or in the maternal and perinatal death surveillance and response systems. Systematic assessment of data quality, and it's really hard to estimate the completeness. But one of the things we see over time in most countries is that there is some consistency, and one can look not only at national level, but also regional level with the maternal mortality data, and try to estimate the institutional mortality with the facility data. And so we're working on making this stronger and stronger. And we can imagine that in countries where the coverage of the births by health facilities is high, that this estimate from what's happening in the facilities should become a very good input into estimating what's happening in the whole population. Next slide. And there's also various other indicators that the teams look at. Family planning is one, and we work together with Track 20, but also primary healthcare indicators such as outpatient and inpatient services and health system inputs at district and regional levels. And then our goal is to move now further towards assessment of subnational performance, which districts need more investments and are lagging, etc. Last slide. So finally, the uptake. There's good uptake of the chart books in countries through workshops and used for different reports. The Countdown and GFF portals have the profiles on them. We have now started working with Gavi, WHO and UNICEF on immunization chart books. And I think there's much potential for using facility data for better monitoring and performance. Many countries have good data. Some don't really have good data, but only by using these data, we can improve them and obtain better investment. And just one last comment, if I may, Cheikh. We learned during COVID, when the survey stopped, that this is the only way to track progress in RM/CAH or how they're affected by the crisis. And we look hopefully at the short one today, when the surveys also have to be stopped because of the US government measures. So thank you all. If there are more questions about the chart books, we're all ready for that.
Thank you so much, Tis, for this, again, very great presentation. I think the chart books are a very useful summary report that we get in the countdown every year from all the countries, and it addresses a lot of issues that we sometimes are not very used to, particularly the issue of HMS data, what to do with them. People, they don't like looking at those data. They are very messy sometimes, and sometimes they are not really accurate. But what we do in the countdown to make them better and get something out of it is actually what is really useful for the countries. So we thank you so much. And you, in your last slide, you're talking about the uptake, which is also critical. And actually, here we see some uptake session in Somalia and in Ethiopia and also other countries, and there are many. And one of them is DRC. And actually, in the next session, we are going to now practically see in which way this profile have been used in DRC, inviting our colleague, Professor Pierre Akilimali. Pierre, donc, on vous donne la parole pour nous parler un peu de comment ces résultats ont été utilisés un peu en République démocratique du Congo. Donc, Pierre, à vous la parole. Merci.
Merci beaucoup, cher Cheikh. Je remercie aussi beaucoup Thiel qui a préparé notre présentation. Donc, nous n'allons pas revenir sur ce que Thiel a expliqué parce qu'il a expliqué le processus. Notre présentation, next slide, please. Notre présentation, initialement, nous avons prévu de parler de l'importance et de la pratique basée sur les données probantes, mais aussi, on allait parler aussi de comment on procède pour élaborer notre chatbot, mais Thiel a déjà parlé de ça. Nous nous focaliserons plus sur l'utilisation des chatbots pour informer le processus de suivi et évaluation annuelle et la prise de décision concernant les domaines sur lesquels nous sommes en train d'analyser ici. Next slide. Alors, quelle est l'importance? Next slide. L'importance pour la RDC. La RDC est un pays confronté aux divers problèmes de ressources. Pas seulement la RDC, d'autres pays aussi africains. Et on est appelé à prendre des décisions pour rationaliser l'utilisation de ces ressources. Ainsi, ces décisions doivent être basées sur les évidences. Et quand vous prenez les cas des pays tels que la RDC, qui est un grand pays, les enquêtes de grandes envergures qui donnent des indicateurs souvent ne sont pas couramment réalisées. Juste pour vous donner une idée, la dernière enquête mixte, c'était en 2018 et la dernière enquête EDES qui a été rapportée, et c'était en 2013. Et actuellement, c'est en 2024 que nous attendons le rapport final des EDES. Et vous voyez ces écarts-là. Et les parties prenantes ont des problèmes pour avoir les éléments pour évidencer l'évolution des différents plans d'action et directives qu'ils sont en train de mettre en place dans le cadre de l'amélioration de la santé de leur population. Et plusieurs plans sectoriels souffrent des ressources de données pour évaluer l'atteinte de leurs objectifs. Et actuellement, pour le cas de la RDC est en train d'implémenter la politique de la gratuité de la maternité, mais pour s'assurer que cette politique est une réussite, il faut avoir des données. Et l'équipe countdown du pays en RDC aide le gouvernement en utilisant tout ce qu'on utilise comme approche, les chatbots et les country profiles pour aider les pays à voir où est-ce qu'il évolue avec les différents secteurs de la santé. Next slide. Alors, comment déjà expliquer, next slide please, les travail au niveau du pays en RDC s'est fait dans une équipe multisectorielle. Nous avons une équipe faite du ministère de la Santé et aussi une équipe des académiciens. L'ensemble de cette équipe travaille pour que les données produites par le ministère, analysées avec le ministère et les académiciens, et être en mesure d'interpréter ces données et les utiliser pour les besoins du ministère de la Santé. Comme le disait tout à l'heure, Cheikh a une des questions, et c'est au niveau du pays, nous, du ministère de la Santé, de voir quelles sont ces informations que nous pouvons utiliser pour orienter les différents secteurs et la prise de décision dans les différents domaines. Next slide. Alors, après la production des données lors de l'atelier, next slide please, à Kigali, l'équipe du pays est rentrée et a préparé la dissémination. Next slide, yes. Nous avons eu les résultats que nous avons obtenus au cours de l'atelier à Kigali et nous avons proposé avant de disséminer, préparer ces disséminations en commençant par faire l'analyse des parties prenantes pour savoir qui doit utiliser ces résultats. Parce qu'il est bien de produire les analyses, d'avoir les résultats, mais il faut les consommer, il faut les utiliser. Et les vrais utilisateurs, c'est qui? Ce sont les ministères de la Santé, ce sont les partenaires qui travaillent dans le domaine de la RVNH. Et donc, nous avons commencé par faire cette matrice Et après avoir obtenu cette matrice, compris qui fait quoi, qui a quel pouvoir, qui a besoin de quels résultats, et ça nous a permis d'identifier les parties prenantes pour organiser notre dissémination au niveau du ministère de la Santé. Next slide. Et ainsi, nous avons responsabilisé le secrétaire général à la santé, qui est le numéro 1 qui s'occupe des aspects techniques de la santé en RDC, qui a pris lui-même, après avoir été convaincu par notre briefing, convoquer les parties prenantes. Next slide, please. Convoquer les parties prenantes pour que les directeurs, les responsables des bailleurs, les différentes organisations de mise en œuvre puissent participer à cet atelier de dissémination. Et on a eu cet atelier qui a été présidé lui-même par le secrétaire général et tous les directeurs centraux, les directeurs des programmes et certains représentants des bailleurs étaient là pour voir l'importance et les données produites au cours de cet atelier. Chose qui était intéressante, initialement, certains parties prenantes qui étaient hésitantes, ils ont été émerveillés de voir qu'on pouvait aussi utiliser les données des routines pour produire des évidences, malgré qu'on doutait initialement de la qualité de ces données. Et ils se sont rendus compte que les techniques que nous utilisons permettent quand même d'améliorer l'utilisation de ces données et produire des évidences intéressantes pour que les parties prenantes les utilisent pour la prise de décision. Next slide. Et après cette dissémination, nous nous sommes retrouvés avec les parties prenantes qui étaient émerveillées et qui nous ont demandé même plus que ce qu'on avait prévu. Et au cours de cette réunion, des grandes décisions ont été assorties de cette réunion. Ils nous ont demandé à ce que nous puissions étendre les analyses des cas dans plusieurs secteurs, qu'on ne se limite pas seulement au secteur de la santé, de la reproduction de la mère et du nouveau-né, mais d'aller là, chose qui est intéressante pour voir qu'ils ont aimé, ils ont été émerveillés. Et ils ont aussi, en particulier le secrétaire général, qui initialement peut-être était hésitant, a été le premier à aujourd'hui nous mobiliser, faire la promotion de l'utilisation des données DHST, qui souvent les années antérieures, on prenait le temps pour les utiliser. Et ils nous ont même demandé de synthétiser pour chaque programme. Et avec ce qu'on avait comme chaque bout, nous avons pris des éléments clés, des informations clés en produisant des posters et des rollouts pour chaque programme. Ainsi, chaque programme et chaque direction centrale du ministère de la Santé était en mesure d'avoir des données spécifiques à leur programme pour utiliser les données. Et le secrétaire général a dû même aussi signer une note circulaire, une instruction allongeant, donnant un peu plus de pouvoir à l'équipe de travail mixte, école de santé publique et ministère pour produire des analyses davantage pour aider les parties prenantes. Next slide. Et ainsi, il a même renouvelé, le secrétaire général, le rôle de cette équipe pays d'analyse. Next slide, please. Et cette équipe a aujourd'hui la responsabilité d'aider, d'accompagner les différents secteurs du ministère pour les analyses des données en spécifique dans leurs programmes respectifs. Next slide, please. Next slide.
Are you moving the slide? Yeah, sorry. Okay, proceed. Thanks.
Yeah. Donc, voilà, et le secrétaire général émerveillé a renouvelé la composition de l'équipe pays pour continuer à utiliser ces stratégies en utilisant les données de toutes les sources, des DHSD, des enquêtes, des données globales pour produire des évidences. Aujourd'hui, l'équipe travaille pour ça. Next slide. En résumé, ce que nous pouvons dire, avec les chatbots et les profils que nous avons, nous sommes aujourd'hui en mesure d'aider, d'assister les différents services, direction du ministère de la Santé à avoir des évidences pour les éclairer par rapport à leur plan sectoriel. Oui, nous avons un plan de 5 ans. À ce jour, nous sommes à quel niveau? Grâce à ces profils, grâce à ces chatbots, certains services, direction du ministère de la Santé, sont en mesure aujourd'hui d'avoir un tableau de bord pour savoir où est-ce qu'ils sont et comment ils évoluent. Voilà en résumé ce que nous avons à présenter avec vous, partager comme expérience de la RDC. Le temps qui nous est imparti ne nous permet pas de vous dire beaucoup. Ceux qui ont des questions, nous serons disposés à répondre dans le chat ou dans d'autres occasions. Merci.
Merci bien, professeur Pierre Akilimali de la RDC et son équipe. Je pense que vous avez fait un excellent travail et ici, on voit vraiment un exemple concret vraiment de comment ces outils, en tout cas ce qu'on appelle le candidat chatbook, a pu être utilisé et pratiquement même institutionnalisé au niveau de la RDC avec un très haut niveau d'engagement. Je pense que ça, c'est excellent et nous vous en félicitons et nous félicitons toute l'équipe de la RDC. Et également dans d'autres pays, je sais que des exemples similaires pourraient être partagés également pour d'autres pays. Donc, merci bien. Alors, à ce stade, je pense que nous tirons un peu vers la fin. Et nous allons, okay, we are going to invite our colleague from GFA, Peter Hansen, oh, sorry, there's another one. I'm sorry, I think there was another one we've missed from Ethiopia. So actually, let me just give the floor to the Ethiopian team to take us through a similar example, but please feel free to proceed quickly before we run out of time. Thanks. That says Mekonnen.
Thank you, everybody. Good
Thank
evening
you.
or good afternoon.
Good evening. Thanks.
My name is Aderajew Mekonnen from Ethiopian Public Health Institute. I will present the analysis of reparative maternal, newborn, child, and adolescent health indicators starting from 2019 to 2023 for the past 5 years. Continue. This is my content or my presentation outline. There is a introduction, facility data quality assessment numerators, health facility data denominators assessment and selection, national and subnational coverage and equity, maternal mortality and stillbirth rate in health facility, health system inputs and service utilization, and the health system performance assessment, as well as key conclusions and key policy recommendations. And the final is the way forward. Next. This is the introduction. The aim of this study is to enhance country or lead monitoring of both national and subnational estimates for key indicators of reproductive, maternal, newborn, child, and adolescent health, or the RMSH, and including health equity. And the second one is to inform national and global reviews progress and performance of the national plan and strategy for RMSH. And the last one is to provide specific attention to data quality through a systematic approach. This analysis was based on the routine district health facility data for the past 5 years and recent national surveys, health system data, and global estimates by providing special attention to data quality. Next. This is the health facility data quality assessment numerators. Here we used the 4 data quality matrices, that is the completeness of monthly facility reporting and the estimate the extreme outliers, consistency of annual reporting, as well as annual data quality scores. When we indicate this one or look at this one, completeness, regarding completeness, the data quality score trend shows that within the past 5 years, it has been declining over the years. It may be due to conflict or COVID-19. Completeness was very low in all the years, with less than 50% of the regions having a completeness less than 90%. In all the years, more than 90% of regions have no extreme outliers. This indicates that there was no problem with extreme outliers regarding the completeness of the data reporting. Next, please. Regarding the reporting rate by health facility type, we use 3 types of health facility, the hospitals and the health centers, as well as the health posts. Then regarding their better reporting, the hospital as well as the health centers have consistent and incremental report. AMC report created by health posts by geography as well as the completeness was relatively low compared to the two or for the hospital as well as the health centers. So enhancing emphasis should be given to the health posts because they are at the lowest level. However, they use it by many customers and the clients. Next. This is also the health facility data denominator selection. We are compared four denominators based on the estimations. That is the HSI2 projection, ANC1 derived, and Penta1 derived, as well as the UN projection. As you see, maybe you cannot see the slide is too low. We compare this results with the national, particularly with the national surveys conducted by the Ethiopian government. The national, using this four denominators, we compare institutional births, Penta3 coverage, then we obtain Penta1 derived and ANC1 derived denominators methods generated close to the survey coverage at national level as well as for the regional levels. Continue.
Yeah, I show you moving very fast,
Okay.
but I appreciate if you go a bit faster. I know we are running over
Okay,
time.
thank you.
Thanks.
The national and subnational coverage trends antenatal care regarding this one. The ANC4 survey coverage consistently increased over the past 5 years. That is increasing by 43%. And the facility ANC4 estimated shows that it's slightly reducing from 2019 to 2020, then started increase to the 2023. This indicates also the regional or the local disparities, particularly we have more than 13 regions. Then among the regions, there is different or there is a disparity between the ANC service utilization and ANC estimates indicators. Next. This is also the subnational coverage trends for Penta3. If you look at the graph, the survey data for Penta3 coverage has consistently increased over the years. This is similar with the EDHS or with the national data surveys. The facility Penta3 coverage estimates, however, shown a steady pattern over the years with only 2% point increasement. Low performing parts of Ethiopia in all the regions includes the northern as well as the eastern and the east part of the country. Particularly, we have Afar as well as Somali regions showed a progressive increment over the years. However, central part of Ethiopia have a relatively better performance throughout the year. Next. This is also the equity analysis. Regarding the equity, we conduct the mean absolute difference from the mean has decreased over the years from 11 to around 10 in 2023. Two subnational areas have extreme values, both in the upper and the lower. Particularly, the northeastern part of Ethiopia, like Afar region, has the lowest institutional live birth coverage in all the years. In 2020 and in 2023, coverage was improved in the most part of the Ethiopia region. Next. This is also the ANC4 and the institutional delivery as well as the Penta3 coverage. In all the years, only few regions have achieved ANC4 coverage by more than 8%. However, the proportion has increased from the 20% in 2029 to 30% in 2023. Regarding the institutional delivery, the proportion of regions with institutional delivery was greater than 9%, is lower than the 30% on the years. The lowest is in 2021. Penta3 is the proportion of regions that achieved Penta3 coverage was greater than 9% in the higher than the 6% all the regions except in 2020. Next. This is the maternal mortality in healthcare facilities. As indicated in the earlier presentation, the maternal mortality is over the 25% per 100,000 in all the years, which is above the threshold level for low and middle income countries, that is less than 25%, 25. There are extreme outliers in all the years except 2022. There is high disparity in maternal mortality between the regions or in all the years. Only few regions have maternal mortality lower than the national coverage. If you see the dots, the green dots are the regional and the red ones are the national survey results. So there is a disparity between this one also. Regarding the national birth to maternal death ratio.
So Dr. Mekonnen, I
Yes.
think you are doing very well. I know we are concerned with the time, but if you don't mind wrapping up quickly in the next 1-2 minutes, so that I know we could share the slide with the team again. Thank you so much.
Okay, thank you. Okay. So the national neonatal mortality rate in facilities dropped from 11 to 40% per 1,000 live births, which is reduction by 61%. The geographical disparity was also here very consistent. Next. Regarding the service utilization, we assessed the OPD utilization among the children under 5 years and all the patients. The OPD per capita for both under 5 and old ages were consistently increased over the past 5 years. And the under 5 OPD service utilization is the lowest in Africa, in APHRC and as well as the Somali and Southwest regions. In short, Addis Ababa region has the highest under 5 OPD service utilization compared to other regions. This indicates that there is a disparity between the regional as well as the urban cities. Next. Can you continue? This is also the health system performance assessment indicators. We assess the hospital bed density ranges from 2.5 to 22.9%. As national, we have obtained 3.8%, which is also different among the regions. Regarding the core health workforce density ranges from 2.7 per 10,000 in Southwest Ethiopia to 11,190 in Addis Ababa. This is the capital city of the country. And the national average of the core health workforce was 13.2. Continue. This also indicates the health system performance assessment indicators. As you see from the line or from the graph, it is also there is an increasement between the national health national survey coverage as well as the health facility as well as the bed correlation with positive correlations. This increase, in short, this indicates the indication of incremental, or it has positive correlation with OPD services utilization as well as the increment of the bed utilization. Continue.
Mm-hmm. Great.
This also the health system performance assessment indicator. Also, this is the health service utilization is highest in urban regions. However, there is also very low coverage in the rural regions. The overall national health performance or health system performance score was 39.1%. From the input infrastructure scores, 58%, and the health scores was 57.4%. Continue. This is a key conclusion. I don't read this conclusion. In short, there is a need to improve the data quality, and there is a call to enhance reporting system for maternal deaths, stillbirths, and other metrics. And there is a need to reduce disparities in service, health service coverage as well as utilization. And there is also health system strength scores low, so indicators improvement. Continue. This also indicates the policy recommendations. There is a need to increase or to enhance the data quality by adjusting denominators as well as other mechanisms. And the coverage and equity was also, there is a persistent disparity between the coverage and equity health, as well as the health workforce distribution. And the maternal, birth, and neonatal services also have disparity. So specific intervention will be necessary. And the health system performance strength monitoring metrics focus on low performance regions is very also essential. Is the maternal reporting system should increase by designing systematic and effective system and strategies. Continue. Okay, this is the last one. Thank you.
Thank you so much, Dr. Mekonnen. I think you have done a wonderful job. I know you have a lot to say, and this is really a very good summary of the wonderful work that you've been doing with the team in Ethiopia. Of course, we all again appreciate your leadership from Minister of Health, from all the APHRC team, to engaging with decision makers, federal government, to make sure that these data are translated into program and action in Ethiopia. Thank you so much. But I first apologize for running a bit beyond time. I know we are committed to stop here, but there are still two main messages that we want to pass by through Peter Hansen from the GFF, who have been supporting. The GFF is a very big supporter of the country team, of the countries in supporting remission funding. So Peter, if you after hearing all of this, how do you appreciate the value of this tool actually in view of resource mobilization and data use? Maybe you have something to say on that, Peter Hansen. Over to you.
Thank you, Cheikh, and hello, everyone. At the GFF, we partner very closely with Countdown on a range of activities, including the annual workshops involving all 26 GFF partner countries in Africa that result in the development of the country chart books. As Tis noted, the country chart books are disseminated through the GFF data portal, making them widely available for use. The GFF liaison officer works closely with MOH, the National Public Health Institution, leading the engagement in each country and other partners to support active use of the chart books through national coordination platforms and other relevant fora. Each of the GFF supported countries has a country-specific page on the GFF data portal where, in addition to the Countdown chart books, a host of data is presented related to their investment cases, resource mapping, and overall progress toward improving ARMN-CHN outcomes. While these data are primarily for countries to use for their own planning and decision-making processes, we also think it's important to make the data publicly available to promote cross-country and global learning. The GFF and Countdown partnership is underpinned by a shared vision of supporting country capacity to collect, analyze, interpret, visualize, and use their own data through their own processes on a regular basis for program and policy development, including investment cases and national health strategies, upon which the investment cases are based, for prioritization and resource allocation decisions, and for program monitoring and evaluation and adaptive management. The GFF Countdown partnership, together with PMNCH, also recognizes the importance of putting evidence into the hands of civil society organizations to advocate for women, children, and adolescents, and to hold governments and development partners to account for delivering on their commitments. As we've heard today from Cheikh, Tashrik, Dee, and Linda, the Countdown country profiles and country chart books present in one place a range of up-to-date demographic, intervention coverage, equity, financing, policy, and systems data. The graphic visualizations convey important information about trends on key indicators and the current health situation in each country in a manner that's easy to interpret, which is necessary for stimulating dialogue in country platform meetings and other stakeholder convenings. Gender and equity are core to the GFF strategy, and as we've heard from Aluisio and Elizabeth, the Countdown profiles and chart books can be used to identify population groups falling farther behind and where more attention is needed to address gender inequalities. This information is critical for designing targeted strategies to reduce disparities and to ensure that women and girls can access essential health services. We heard two excellent examples from DRC and Ethiopia on how they use the analytics on the country chart books to inform their annual review processes and development of policy recommendations. This is the goal of the GFF Countdown Partnership to support country development of robust analytics and the translation of these analytics into policy and action. A major role of GFF is to facilitate partner alignment, including around resources and technical support to country-identified priorities. Tools like the countdown profiles and the chart books enable country-led prioritization based on strong evidence to which GFF, the World Bank, and many other partners can align their support. To conclude, I'd like to say a short word of thanks to all colleagues and partners who have been part of this important collaboration and whose hard work over a multi-year period has made this a success. I'd also like to thank PMNCH for organizing today's webinar. Thank you.
Thank you so much, Peter, for this very nice word. And again, we really thank you, GFF, for this continued support to Countdown and to all these countries, because you've been working with these countries over the years, and we are seeing the impact of your support in those countries. Thank you so much, Peter, for this support. So at this stage now, we are going to invite maybe the most important elephant in the room here, Dr. Rajat Khosla, who is the Executive Director of PMNCH, who have been supporting this great initiative for advocacy, for all the work that we do in the Countdown. We would invite him to not only share closing remarks, but also to tell us a little bit of why we think these tools are really useful for advocacy. So Dr. Rajat, sorry again for taking you over time, but we are happy to have you use us. Over to you.
Not at all, Cheikh, and thank you. It's a pleasure to be here. And let me start indeed by thanking all the speakers today for this excellent discussion and extend my heartfelt thanks to the Countdown for their continued focus on advocacy and accountability for reproductive, maternal, newborn, child, and adolescent health. As the world's largest alliance for women, children, and adolescents' health and well-being, PMNCH knows very well that what gets counted gets done. And it is this approach that we bring to our roles in mobilizing, aligning, and amplifying the voices of our 10 constituency and over 1,500 partners across the world. Women, children, and adolescents are disproportionately impacted by compounding global issues, and prioritizing their health and well-being must come backed by relevant evidence for translation into advocacy and action. And sincerely, the last 2 hours of the discussion has made this point repeatedly on how important evidence and data are for advocacy, and how country data products and profiles and chart books are integral to advocacy for women, children, and adolescent health space. These products, as multiple speakers have very eloquently identified, can help us in numerous ways. Firstly, identifying health gaps and priorities. Data helps identify specific health challenges faced by women, children, and adolescents, such as maternal mortality rates, vaccine coverage, adolescent mental health issues, etc. The Ethiopia presentation, for instance, was a very eloquent example of how we can achieve these issues. Furthermore, it also helps us with measuring impact for intervention. Tracking health data allows advocates to monitor the success of programs aimed at improving the well-being of women, children, and adolescents. The examples that we heard about data on prenatal care access, childhood nutrition, or school health program helps us assess whether these initiatives are improving health outcomes and where improvements might be needed. Data also helps in monitoring and accountability and allows us for tracking progress on health initiatives and programs over time. These issues ensure that resources are being sufficiently and efficiently being used and allocated to different aspects of health programming and ensuring transparency and accountability. And ultimately, they help in shaping policies and funding priorities. And Peter very nicely highlighted how GFF is undertaking these aspects into the different aspects of the work. These are testing times for global health, and already vulnerable women, children, and adolescents are increasingly facing multiple obstacles to their health and well-being, including compounding effects of climate crisis, economic downturn, rising conflicts, and humanitarian issues. Advocacy, supported by rigorous evidence and data, is essential to ensuring the future of global health, and PMNCH is committed to ensuring vulnerable communities and populations are protected and their health is prioritized. Amid global instability, and imperative to protect the most vulnerable is higher than ever before. Thank you really for everybody for joining us for this session, and back to you, Cheikh, for closing.
Thank you so much, Dr. Rajat, for this also very strong message and these strong words. And we again appreciate all the support PMNCH have been providing to this initiative. And of course, everything is important, but nothing is less important than advocacy, making sure that these results are translated into program action for a better well-being. So at this stage, I would like to thank everyone who attended this long webinar, but very important webinar. I think the profile, we never emphasize the usefulness. We never emphasize the way they should help. They are going to help countries to adjust their policy and program. But we thank everyone for being here. So we know that all the material that have been presented here will be accessible through the website, through our other channel, and we thank all the presenters who have been here from the countries, the RDC, Zambia, and Ethiopia, and all the other 20 countries who have not been able to speak today. Jennifer and team who have been tirelessly working behind the scene, Elizabeth and all the Johns Hopkins team, so Coretta and team, so everyone, thank you so much for being here, and have a great evening, have a great day, have a great night, depending on where you are, and see you next time. Bye-bye, thanks.